how are you? My name is Dr. Rishi Desai. I'm the Chief Medical Officer at Osmosis, and I'm here to talk about COVID-19. A lot has changed in the past few weeks. One thing that is consistent is that COVID is still with us. And so I wanted to talk about any questions you might have. And if you have those questions, please put them in the chat, and I'll try to address as many as we can get through. In the meantime, I thought I would just kind of lay out some of the things that we are probably going to be discussing through the questions, just as a bit of a preamble. So first, vaccines are on everyone's minds. Right now, we know that Pfizer has announced that they have a vaccine that seems 90% efficacious, which is great. It means that we have something that we can talk about specifically, what that means, what that number should be kind of thought of in terms of like what the real world implications of that is. And to back up it just a little bit, I wanted to talk about how vaccines even get to this stage. So again, as a recap, there's phase 1, phase 2, and phase 3 trials, meaning that every vaccine that's going to be tested goes through each of those phases, has to go through all 3 phases and be successful to be used on human beings in the public. And all 3 phases are done on test subjects, people that are in the trials, clinical trials, are generally healthy adults. And so healthy adults are getting the vaccine in phase 1. And really the question is it safe? So typically they'll look at the vaccine for about 6 to 8 weeks and see, did people have any side effects? Did it seem safe? And once that happens, they say, okay, this seems like a safe vaccine. Let's move to phase 2. In phase 2, you give the vaccine now to maybe 100 folks or 200 folks, somewhere in that range. And here you're saying, let's just change the dose, the amount of the vaccine that we give, to see how much you really have to give to get a good immune response. So you draw blood from the person and you check what their antibody response is. And if it looks like it's really solid, you'd say, okay, this is actually a vaccine that we think we can give in a lower dose because we're still getting the same immune response. So phase 2 is really about like, what's the lowest dose you can give to really still be immunogenic? That word just means mounting a good immune response. And then now you figured out that dose, you go to phase 3. Phase 3 is where you give it not to, let's say, a few hundred, but maybe a few thousand people. And at that point, you're saying, okay, now we're going to give it to these people, and we're going to compare how people with the vaccine are going to do versus people without the vaccine. And in those 2 groups, is there a difference in terms of who contracts COVID-19? Because if there is, then we believe it's efficacious. And so that word efficacious, I want you to just kind of remember that word. What we're seeing from Pfizer is that it seems like this vaccine is 90% efficacious, meaning 90% reduction in the number of folks that got disease, which is incredible, right? That's a really great statistic. And what we'd want to know right away, and once we see the data, we'll get a better sense of this, is does that really diminish mild disease? Or is that really also diminishing moderate disease and severe disease? Really, that's what we're worried about, right? With our healthcare system is hospitalizations and deaths. You're not really worried about, averting a bunch of runny noses. That's maybe a nice to have, but what you really want to do is avert serious illness. With the runny noses, the mild disease, the one huge benefit that could be had there is reducing the amount of spread. So these are the kinds of things you want to look at when they say 90% efficacious. What kind of disease was that really blocking or reducing? That's the first thing I wanted to mention. Now, let's say that this vaccine goes through phase 3. We say, hey, this is great. Let's roll this out. How does that happen usually? Does that mean that one day everybody across the world just gets the vaccine? No, that's definitely not what's going to happen. Instead, what's going to happen is we're going to have to figure out the logistics of how much vaccine can we make and who should be the first priority for getting that vaccine. Typically, in the US, the way that happens is there are committees and they make recommendations, and other committees look at those recommendations and kind of essentially create the final decision about how it's going to be rolled out. ACIP is a group that basically helps to lay this out for immunization practices. That's what the IP refers to. So that group is going to give out a list of kind of priority groups, like, hey, first, vaccines should go to healthcare workers, healthy healthcare workers that are not sick with other chronic conditions. They should be the first group to get the vaccine. That's probably most likely what's going to happen. After that group, and that would be nurses, doctors, EMTs, other frontline healthcare workers. After that group, The second group that might be considered for the vaccine might be folks like the elderly, maybe folks that are in nursing homes or other places like that. And so that would be another kind of core group that you'd want to get the vaccine out to. After that, the third group that might get some priority here would be adults. So this is kind of the more generalized population. After you've already kind of given it to healthcare workers, you've given it to the elderly, maybe at that point you give it to adults. Once the adults get the vaccine, then we start thinking about, should kids get vaccinated? And again, these are not the folks that are tested in the phase 1, 2, and 3 trials. We're not usually testing them on children. And so at this point, you've kind of you've given it to enough people, you've seen how it works in the public. So at that point, maybe people feel comfortable giving it to kids, and they probably would give it to 5 to 17-year-olds first, the older kids. And then once that group gets it, then you give it to the kids that are 5 and under. So those are kind of the ways that this usually gets rolled out. Just to recap, high priority groups would be healthcare workers, the elderly, that's where a lot of the death and disability and hospitalizations is happening. Then maybe adults, and then maybe kids that are older, then maybe kids that are younger. And maybe there are other kind of subgroups that we might think about as well, like, pregnant women and other groups that might be a little bit more high risk that you might kind of put into different categories. So that's usually how it's figured out in terms of how you roll this out. And each group, you have to keep in mind, the reason we're doing it in groups is to see if it's safe. Is it really effective? So you still want to get more safety data, more effectiveness data. And that's why you want to kind of roll this out in phases. And so each phase might be 6 weeks or 8 weeks. And maybe some phases overlap with other ones, because you have to keep in mind that you're not going to get vaccine out to every elderly person all in the same day. So it might take a few weeks even to kind of roll it out in a given phase. But that's how you want to do it. You want to kind of have one phase, kind of go through, get some data on them, then do the next phase, get some data, do the third phase, get some data, et cetera. So that by the time you get to the most vulnerable people, the kids, you really have a good sense that this is a good vaccine, has a good track record, very effective and very safe. So that's usually how it's going to go. And if you just kind of do the math on that, 6 weeks, 8 weeks per group, and if I'm saying 5 groups, that's already about 10 months of time to roll this out. So clearly, whenever the vaccine hits, it's going to be a while before different groups get the vaccine. And even if everything goes flawlessly, it's going to be the better part of the year before this gets rolled out to everybody. So that's the first point I wanted to make, is just the timing of it. The next thing is, if you caught it, I talked about efficaciousness, but then later I said effectiveness. These are two different words. So efficaciousness is when Pfizer tries to use the vaccine in a controlled setting, how efficacious is it? How does it work in that sort of perfect controlled environment? And they're saying 90%. That's really good to know. 90%, great number. But that's, of course, everyone getting just the right dose, the vaccine being at just the right temperature. All of the vaccine was thought to be working. It's not like it was, for whatever reason, deactivated because it was sitting out on the counter for too long. None of those kinds of things. So really, this is a perfect scenario. You get to 90%. Now, in the real world, you've got all sorts of problems, right? Like you might have a situation where someone says, hey, I wasn't able to actually get this vaccine on time because the truck was delayed, or the shipment didn't come in on time, or all sorts of kind of real world problems that happen with vaccine logistics. And so when that happens, now the effectiveness is not 90%. Now the effectiveness falls to 80%, 70%, maybe 60%. And so this is another consideration, is that the effectiveness is not going to be that perfect 90% that we think about from the Pfizer study, because in the real world, it's always usually pretty low relative to that perfect setting or that goalpost. And it's going to be low also in this case because we've never done this before. We've never had to roll out COVID vaccine. And you can imagine how much trouble you're going to get into as you try to roll it out in one setting and someone says, I couldn't get vaccine, and who knows what's going to happen operationally. And so again, that's going to probably reduce the effectiveness of that vaccine below 90%. Now, keep in mind that a while ago at the beginning of this pandemic, we were talking about R naught. Now, if you remember, R naught is kind of this number that we said was 2 or 2.5. In other words, for every one person that has COVID, how many more people are going to get COVID? And so if we believe it's 2 or 2.5, that means that it's spreading. And really, you want it to be that fewer people are getting COVID, right? You want the number to be less than 1. And the way to get it less than 1 is by immunization, is what we're talking about, vaccines. Now, to understand what the herd immunity threshold is, again, what percentage of the people in America need to, or around the world, need to get the vaccine to reduce the spread, there's a mathematical relationship. And it is that the herd immunity number, whatever that percentage is 1 minus 1 over R naught. So I'll just say it again, herd immunity, whatever, how you want to calculate that math works out to just being 1 minus 1 over R naught. So if we think R naught is 2, then it's 1 minus 1 over 2, or 50%. That's herd immunity. If we think R naught is 2.5, then we'd say it's 1 minus 1 over 2.5, which ends up being 60%. So when I say herd immunity threshold is 50% or 60%, at least now you know where those are coming from. So let's just choose the higher number, just to be a little conservative. Let's say that to really get COVID-19 levels down, we need 60% of the population protected, 60%. Now, to get to that number, think about it. If the vaccine efficaciousness is 90%, but not everyone takes the vaccine, then you're not going to get to 60%. So what is the fraction of the population that has to get the vaccine? The fraction works out to be 2/3, right? So 2/3 times 90% is 60%. So to say this more succinctly, we need to get 2/3 of people vaccinated if we want to hit herd immunity. If less than 2/3 of people get the vaccine, we're not going to hit herd immunity. And this could potentially continue to grow. So I just want to kind of put that number out there so we recognize that this is our target. And if we want to get to 2/3, that means we need to do a lot in terms of making sure people understand what's happening with the vaccine, that, is it safe, is it not safe, kind of quelling the myths and all sorts of disinformation that's going to happen around the vaccine. So I just want to kind of put that out there as well. Now, there is a question around how long will the immunity last? So if you get the vaccine, what is the evidence that it's going to last for? A week, a month, a year, 10 years? We obviously don't have the track record with COVID-19 because it's only been around for less than a year. So we don't really know how long immunity with a vaccine would last, but there are some good data points. So for example, if you look at how long immunity lasts against other coronaviruses, we know that for MERS and SARS, we've had time to look at those. Those are other coronaviruses. The immunity lasted on the order of years, so at least a few years. So we know that. We also know that the natural infection is probably not going to be as good at giving you long-lasting immunity as the vaccine, which seems counterintuitive, right? Like, why is the vaccine potentially even better than the disease itself for giving you immunity? And the reason is that when you get the natural disease, you actually have your immune system suppressed. Whereas if you get the vaccine, that doesn't happen. You get a really robust immune response. So there is a good chance that actually the vaccine could last longer than we see with natural infection. But honestly, this is only going to be known as we give the vaccine out and as we follow people over time to see what kind of a natural response they have. And it's not just antibody levels. It's also having cells in your body that remember the virus and the vaccine and can then re-establish new antibody. So even though your antibody levels may be low, if you have what are called the memory B cells and memory T cells, you can reestablish an immune response, even if you're given that virus many years from now. So in all likelihood, immunity will probably be on the order of years, not months, not days, not weeks, which is a good sign, but that doesn't mean that you will have it for maybe 10 years or 20 years. So there's also a chance that maybe we'll have to get a COVID vaccine every 5 years or every 3 years, whatever that interval ends up being. So we might have to go through this song and dance again once the vaccine is out there, where people have to have that as part of their natural set of vaccines, whereas that didn't used to be the case. So there is a good chance we'll have to follow this over time, see how long it is, probably on the order of years, and then may need revaccination if necessary. Another question, what do you think is the primary force driving the current wave of COVID-19? Well, it's a good question. I think it's essentially being driven by a couple of factors. The number one factor being our behavior. So as we behave very conservatively, wearing masks, socially distancing, not getting together in big groups, we know that the numbers go down. As we start reopening universities, as we start not wearing masks, as we start gathering in big groups, whatever the reason may be, the numbers go back up. And so it's very clear that this is really in direct proportion to people being around other people in an unsafe way, meaning kind of close together without masks. That's the number one driver. Now, some of the other drivers are somewhat hypothetical. It could be that during the winter season, it survives longer in the environment. Maybe that's true. And certainly it's cooler now in November than it was in the middle of July. And so there is a possibility that maybe it's surviving a little bit longer in the environment. Maybe that's contributing in small part to it. Maybe there's a behavioral reason. Maybe the fact that we as a group are all sort of indoors more. It is cooler. People spend more time indoors relative to the summer months. Maybe that's part of it. Maybe it's because of other viruses that are circulating more now. So we've got flu circulating, and maybe there's no rule that says you can't have flu and SARS-CoV-2. And so maybe the flu virus is causing your immune system to be a little bit weaker, or affecting some of the cells in your lungs, and those cells are more likely to get infected by SARS-CoV-2 causing COVID-19. All of those things are possible. I think what seems very clear, we've seen kind of 3 peaks now. This is the third one, and it seems like every single time it's very related to our behavior. And so what I suspect is that if we had a national mandate, or even in some countries that's already happening, but certainly in the US that's not happening, if we had a national mandate or requirement to wear masks, I think that we would see a dramatic decrease in the number of cases a couple of weeks after that mandate went through. And that's going to continue to be the case. So I think that that's part of it as to why we're seeing this huge wave. I'll also point out that we're seeing now 6 or 7 weeks of increased cases in the US, which is really worrisome. The number of hospitalizations have also gone up. So usually there's a lag. A couple of weeks after the cases go up, you see hospitalizations go up. And then a couple of weeks after that, you see deaths go up. We've seen all 3. So now that we've seen those hospitalizations and deaths increasing, especially in certain states, it's very worrisome. And certainly this is a trend that will happen not just in the US, but in many countries around the world, and many parts of the world are seeing this. And so it will affect hospital capacity. Hospitals are going to start filling up again. As those hospitals fill up, they're unable to take care of patients as effectively. And so patients sometimes get discharged on oxygen still, and then can have worse outcomes, including death, because they're not getting the level of kind of care that they otherwise would have gotten. So this is why this kind of starts to spin out of control. So these are some of the issues, and of course, a segue, I guess, into the winter season. So, in the US, we've got Thanksgiving coming up. Around the world, many people celebrate Christmas. And so with these 2 holidays, a big part of these holidays traditionally is being together with family, right? So you often spend time with friends or family, and you get together in a group. And sometimes those families haven't seen each other for a few months. Maybe kids are away at college, or people live in different parts of the country and kind of get together for a family get together every Christmas. So whatever the reason is, but you have people kind of coming together sometimes that haven't been together. And so this is another cause for concern and caution. So if you are thinking about getting together with family, just a few things I want to kind of mention around the holidays. So first, if you're going to do it, think about it from the perspective of kind of going to the holiday, being at the holiday, and then returning from the holiday. So when you go to this kind of location, let's say you're going to a family member's house, on your way there, just think, A, am I going to get tested before I go? B, am I going to isolate myself for, let's say, 2 weeks before I go? That way you at least can, to some degree, feel comfortable knowing that you aren't bringing COVID-19 to the party. Because if you have isolated for 2 weeks, presumably if you were going to have symptoms, you would have shown them. If you were going to be an asymptomatic carrier, you would have gone through that experience as well, and you shouldn't be shedding, a couple of weeks out. Certainly we've seen that some people shed much longer, but generally speaking, 2 weeks is a good window to capture most people. And then finally, how are you traveling there? If you're going to this event, are you flying to the event? Are you driving? Are you going with other people? Maybe carpooling or something like that. Whenever possible, try to go in a way that doesn't expose you to other people. So if you can drive alone, that would be ideal. If you can drive with just your little family unit, that's ideal. Hopefully you're not taking a train or a bus or a plane, something where you'd be exposed to a lot of other people. So that's the first thing. Once you're there, think about how you're going to potentially expose other people. So let's say someone came to this party, they brought COVID, they didn't know it, but they brought COVID to the party. How do you minimize that disease from spreading to other family members? Well, one, see if you can't host an event that's outside. So just do something outside. At least wind is your friend. It can help dilute and essentially make the amount of virus that anyone inhales much lower. So if you can do something outside, that's ideal. Also, try to make it so that maybe you're there just for a single dinner or a single event rather than spending the night. Again, it's a time issue. So the more time you're spending with a certain group of family members, the more risk you're all posing to each other. So if you can make it a single event versus spending overnight, all those things kind of make a huge difference. And then, of course, wearing a mask and making sure that you're socially distancing when you're not eating food. And when you are eating food, making sure you're spaced away from other people. So all those kinds of things help to minimize the risk at the event. And then finally, there's the trip home. And a lot of it is going to be the reverse of what I said when you're going there. So on your way home, again, try to drive alone if you can. Make sure that when you get back, you can potentially test yourself or isolate yourself for a couple of weeks if that's possible. All ways of trying to minimize your exposure to other people. Now that you've had this event, let's say COVID did kind of spread at the party, at least now you can minimize it spreading to your contacts and your friends back home. So those are things that you can do to try to minimize the risk of COVID-19. And of course, this is going to be challenging depending on your own situation, but these are general guidance pieces, and hopefully some of this can be applied to your situation. So let me jump in and just see if there's some other questions. One is around antivirals and why are they not effective in COVID-19? I would say that there are many antivirals that have been looked at, everything from drugs that we've used against HIV, like lopinavir, ritonavir. Remdesivir is very, very talked about, and there are lots of studies now that have looked at remdesivir specifically. What we know is that the two things. One is that some trials have shown, and I'll talk specifically about remdesivir because there's the most data I think that's in the public sphere about that, is that some studies have shown that remdesivir does seem to help, does seem to shorten the amount of time they're in the hospital. The WHO study on this actually did not show that and showed that actually did not seem to be particularly effective. So when you get conflicting messages like that, it is confusing. And what I'll say is that typically that would mean that either it's not effective, right? And that first finding was sort of spurious or random and it wasn't true, or it is effective and maybe it's not that effective and therefore it's hard to actually tease that effectiveness out unless you do a huge study. Now, microbiologically, the antivirals are fighting the virus. And typically when people get really sick, at that point, their immune system is so revved up that even destroying the virus is kind of no longer the main issue. It's that their inflammation is sort of so severe that that's what's causing the damage. And again, we know dexamethasone, which is a steroid, helps. So antivirals, I think they do have a role. It seems like their role would probably be earlier on in the therapy when the virus is kind of the biggest player actor in making someone sick. But when it's later stage and they're very sick, it's usually inflammatory, and that's where things like dexamethasone probably are more useful. So that's probably why we're getting mixed messages on antivirals, and it still remains to be seen if those are going to be useful. There was a question about vitamins. I'll say that the one vitamin I'll plug where there's the most evidence right now around it being useful is vitamin D. So taking a vitamin D supplement seems useful, especially for folks that have low vitamin D levels. And so if you know your vitamin D levels are low or that you're suspected to be low based on your lifestyle, if you're mostly indoors, taking a supplement is a good idea. And it does seem to be useful, not just for COVID-19, frankly, but for many respiratory viruses. How to encourage family members to take these measures, that's a hard conversation. A lot of family are tired, they're fatigued, they're maybe feeling depressed or anxious and lonely. And all these things are very real. And I think just having a very honest conversation about the fact that everyone is feeling this way right now for the most part, and that the only way we're going to get through this is by kind of pulling together and staying positive and doing the things that we know are important. So eating well is more important than ever. Sleeping well is more important than ever. Staying physically active is really crucial. Doing those kinds of things is what's going to get us all through this. And rather than telling family members about that, rather just do it yourself. And by doing it, you're sort of being that example for family members. And I firmly believe you can't really fill people's cup unless your own cup is full. And so if you can fill your own cup with good activities, like I just talked about, sleeping well, eating well, and being active, then you can be a really strong support for other people in your friends and family circle. One final question, does COVID have, why in some cases is COVID, fatal, and in other cases it can be fairly mild? This is one of the many mysteries I think that we're still going to have to unpack, and we're going to be looking at this question not for months, likely for decades. And now that COVID is part of our kind of human story, we're going to have to understand better, why is it that some people get so sick? What makes other people more resistant to it? And there are some clues. Age is probably the biggest clue we have. We know that young people generally do much better than old folks. And so that's one clue. We know that it affects people with pre-existing blood vessel conditions, and we know that COVID-19 is a disease of blood vessels as well as a disease of the lungs. And so these are some sort of clues that help us figure this out. But honestly, it's a good question, and not one we're going to be able to answer for a long time. So I've gone through a lot. I know it's been roughly 25 to 30 minutes now, and a lot of great questions have come in. We really appreciate the questions. We really appreciate the enthusiasm folks are having for understanding COVID-19. I just want to say a heartfelt thanks for everyone that joined today, and hopefully you can kind of spread this message of good information and staying positive to your own circle of friends and family. And just remember that we have your back on COVID as well as anything that comes your way. Osmosis is really here to be as supportive as possible. So thanks for joining today, and I'll see you next time. Take care.